In this module, we will learn about the resuscitation bag. We know that nearly 3 to 5% of all newborns need assistance for breathing at birth. Assisted ventilation devices are needed for those newborns who require positive pressure breaths. These include primarily the self-inflating bag and the flow inflating or the anesthesia bag. So, it is very important for us to learn about their parts, correct use, applications and upkeep. The self-inflating bag, also called the manual resuscitator, inflates automatically by elastic recoil and does not need a compressed gas source. It is portable and it remains inflated and ready for use in case of an emergency. The automatic re-expansion and consequent simplicity of use is an asset for the inexperienced operator. Let us now discuss the parts of the self-inflating bag. The parts of the self-inflating bag are air inlet, oxygen inlet, the bag proper, pop-off valve, valve assembly and the patient outlet. One can attach the oxygen reservoir at the air inlet if higher concentrations of oxygen has to be delivered. This is how the parts of the bag can be dismantled. Here you can see the air inlet, the oxygen inlet, the bag proper, the pop-off valve, the valve assembly and the patient outlet. The air inlet draws in air into the resuscitation bag as it expands through a one-way valve. Alternatively, the reservoir can be connected to the air inlet if one desires to give higher inspired oxygen concentrations. The oxygen inlet is usually located next to the air inlet. It is a small projection to which oxygen tubing is attached. In a self-inflating bag, the use of oxygen is optional. The bag would deliver room air when used without oxygen. However, it is required when the infant is to be resuscitated with higher inspired oxygen concentration. The patient outlet is where the air exits the bag to reach the infant through a face mask or an endotracheal tube. The patient outlet may be attached to either round masks, which are available in 3 sizes, namely size 00, 01 and 02, or anatomical shaped masks. The anatomical masks are shaped to fit the contour of the face and are aligned with the most pointed portion fitting over the nose. It is easier to obtain good seal with these masks. Face masks can be cushioned or non-cushioned. Cushion masks have a rim made of foam rubber or an air inflated ring. The cushion masks conform to the shape of the baby's face more easily, making it easier to obtain a good seal and also cause lesser trauma to the face. Self-inflating bags have a valve assembly located between the bag and the outlet. When the bag is squeezed during ventilation, the valve opens, releasing air or oxygen. But during re-inflation of the bag, it closes, thus preventing rebreathing of exhaled air. The pop-off valve or the pressure release valve is an inbuilt safety mechanism of the resuscitation bag. It opens when the pressure generated rises in excess of 30 to 40 centimeters of water. This limit may differ depending on the type of the bag. The advantage of the pop-off valve is that excess pressure is prevented from getting transmitted to the patient. In some bags, this may be temporarily occluded to generate pressures in excess of 40 centimeters of water to expand very stiff lungs. But we should always have a pressure gauge attached to it to monitor the pressure delivered. To close the pop-off valve, depress the valve with a finger or twist the valve into closed position. Some self-inflating bags have an additional site for attaching a pressure gauge or pressure manometer, which is attached to a small projection next to the patient outlet. It allows better control of pressure and ensures patient safety. Although oxygen tubing can be connected to the self-inflating bag, it cannot deliver more than 40 to 70% concentration of oxygen, as air is also drawn in simultaneously. This can be prevented by attaching a reservoir to the air inlet. The reservoir provides a chamber filled with high oxygen concentration and permits the administration of 90 to 100% FiO2. The reservoirs may be either closed-end or open-end. Open-ended tubes are provided with corrugations to increase the volume of the reservoir. The open-ended tubes can also be used to deliver free-flow oxygen. When oxygen gets consumed from the reservoir, it is drawn into the tube in a laminar fashion. Let us see the following picture. When the self-inflating bag is used without a reservoir, air is also drawn in simultaneously as the bag empties. Thus, a mixture of air containing 21% oxygen and 100% oxygen fills the bag. This would deliver around 40 to 70% concentration of oxygen to the patient. When the self-inflating bag is used with a reservoir, it provides a chamber filled with high oxygen concentration. During re-inflation, the bag draws in oxygen-enriched gas rather than room air. This permits the administration of nearly 90 to 100% FiO2. The ideal capacity of the bag for neonates is 240 to 750 ml. In babies with a weight of less than 1500 grams, the volume recommended is 240 to 350 ml. Ladle bags are available in 240 ml and 500 ml size, whereas the ambu bags are available in the three sizes as shown here. Let us now see the clinical applications of the resuscitation bag. The indications for the use of the resuscitation bag are apnea or gasping, or heart rate less than 100 per minute according to the NRP 2010. However, the bag is not to be used in congenital diaphragmatic hernia and meconium stain. Before using the resuscitation bag, one should always test the bag by blocking the patient outlet by the palm. Squeeze the bag and feel the pressure against the palm and the opening of the inspiratory valve. With higher pressures, one may open the pop-off valve. Adequate ventilation is judged by the following: good chest rise, heart rate more than 100 per minute, improvement in color, improved air entry and better saturations. Now that we have learnt the clinical applications of the self-inflating bag, let us learn some important considerations while doing decontamination of the bag. The bag is to be washed with warm water using a detergent after each use and rinsed with clean running water. The whole bag except the reservoir can be autoclaved or boiled. For chemical disinfection, the bag is to be inserted in 2% glutaraldehyde for 20 minutes and sterilization is done if the bag is dipped in the same solution for 6 hours. Before reuse, clean with distilled water, dry the valves and reassemble the bag. When not used, the bag should be disinfected every day with Bacillol spray. Ideally, after each use, the bag is to be completely disassembled and cleaned by rinsing it in water and sterilized. Ideally, after each use, the bag is to be completely disassembled and cleaned by rinsing it in water and sterilized. However, in a busy tertiary hospital catering to around while using bag and mask ventilation, look for chest rise. If there is inadequate chest rise, the possible causes should be inappropriate seal, inadequate inflow of gases, or inadequate pressures, or airway obstruction. This can be tackled by the following. Check the face mask seal. Reposition the infant's head. Lift the jaw. Consider suctioning the airway. Check the bag for any leak. Ensure adequate flows and consider hiking pressures if the above measures fail. Gastric distension is another known complication of bagging and can be managed with the insertion of an orogastric tube to decompress